We can post it on our website. So at this time, thank you everybody again for joining us. We really appreciate you giving us our time. I'm going to turn it over to Janet this time.
Well, thank you so much, Patty. I am thrilled to be here. I think this is such an amazing opportunity to enlighten and help make a difference. And I just appreciate you including me in on this. I want to just jump right in. It was in 2010, in June of 2010, that the Dallas County Commissioners Court passed a resolution unanimously to create the Dallas County Intimate Partner Fatality Review Committee. And it was basically with the thought of coming together and honoring lives by reviewing their deaths. And at the end of the day, could it have been prevented? We always end every presentation with, could it have been prevented? There was one case that I remember that we actually shared, I'm just going to guess I say it that way, we shared with Tarrant County. It was a woman who had experience in Tarrant County, experience in Dallas County, and I believe she was murdered in Dallas County, but had all this other back and forth, lived in one place and worked in another. Anyway, we decided we would connect with Tarrant County and review this case together. And one of the things that came out of it was the knowledge that this woman had been from one medical facility to another, to another, to another, and had never been asked, are you safe at home? Is someone hurting you? How did this come about? And the going from hospital to hospital is not uncommon at all. We see that so many times here at Genesis with clients who, are prescribed this because she can't eat, can't sleep, and cries all the time, and comes over here and says, I sleep all the time. And so another med is on top of another med without understanding the entire picture. Anyway, with that conversation, and I want to applaud everybody's transparency for just sort of laying their cards on the table, we realized that the healthcare system could make an incredible difference in regards to saving lives. It's what you all do every single day, but was in particularly with survivors of domestic violence. And so we came together and created this council, hospital council, that we could talk about these kinds of issues. And as soon as we sat down, we started talking about screening. And so you're going to hear more about that from my colleague, but I just wanted to let you know how this all came about. We continue to meet, we continue to have these conversations. And so the goal of this, and am I supposed to advance? I'm sorry, Marianne, are you advancing the PowerPoint or am I?
I sure can. I can do that.
Okay, I think it's up to you. Thank you. So the goals of today are several. We want you, and basically it kind of comes down to, we want you to know the symptoms. We want you to recognize the symptoms, know the treatment, and be part of the cure. And how that happens is there will be a prevalence of patients. You need to know just how incredible this equal opportunity epidemic is, and how many of them do not end up in my shelter, do not end up on the steps of the courthouse or the police department, but they end up in your medical facilities, your offices, in your EDs. We want you to know that you have a unique opportunity, as I mentioned earlier, but also be able to identify the community resources and be able to engage others, I guess, into helping with that cure. The statistics are alarming. I know we all tracking COVID statistics and all kinds of health issue statistics, but the studies say that 1 out of every 4 women in the United States will know domestic violence on an ongoing basis. Now in Texas, however, it's much more dangerous for us. It's 1 out of every 3 women will know domestic violence, 1 in 3 teenage girls. So our daughters and our granddaughters are also at very high risk because of the numbers of folks we have here here in this conversation. Some of you already know what I'm talking about. You were that little girl that, you know, hid in the closet or under the bed. You were that young boy who tried to get dad or stepdad off mom. None of us are immune from this. This doesn't just present in our charity hospitals. This happens in North Dallas and South Dallas and, you know, East Fort Worth, everywhere in between. It just knows no boundaries. Domestic violence is actually the leading cause of injury to women in the United States. More of us will present to the emergency rooms of our area hospitals as a direct result of all of us who come to you as a result of rapes and car wrecks and muggings combined. Now, I don't walk in there and say, I'm here because he smacked me. What do you all think I tell you? What do you think I say when I walk into your medical facility? I tell you that I have, you know, I fell. I tell you that I cut myself while cooking. I burned myself while ironing. I slipped and I fell. Thank you very much. I walked into a door. I have migraine headaches. I have an eating disorder. I have trouble with my pregnancies. And however, these, ladies and gentlemen, are merely the symptoms. The illness, that is the violence that's perpetrated against me in my own home. So we have to look beyond what she's saying. In fact, I was not long ago, I was over at a church and I was talking with the clergy who do counseling, and I was saying, don't just look at the list of what happened to me. I fell, I burned myself, or whatever. What was the impact of that? You know, when I cut myself while I am cooking, which seems to happen often, or burn myself while I'm cooking, it doesn't have an impact other than I need stitches in my finger. But if she has a traumatic response to that, look at the responses she has to the injuries that she says. Let's move forward on this one with why does he do it? This is not the number one question I'm asked, but it is the one that we should be asking. Instead of why doesn't she just get out or whatever, why does he do it? What kind of coward beats the mother of his children? What kind of monster hurts his partner or spouse? And by the way, I use she as the victim and he is the perpetrator, because in 95% of the time, that is the case. The woman is the victim. The severity is much greater when the woman is the victim. But there are men who are battered by women, by same gender partners. But at Genesis, this is with whom we work, battered women and their kiddos. But let's get it straight. What is the number one question we should be asked is, why does he do it? We know why. We know he does it because he can. He does it because it works. And he does it because we as a society have not found the impetus for him to change his behavior. Why should he? He's getting what he wants, when he wants it, how he wants it. You know, she's responsible for making it happen. And you know what? He can punish her if she doesn't make that happen. If you'll go to the next one, Marianne, a lot of people think this is about a fight that gets out of control. It is absolutely not. It's all about power and control. And if you look at this this wheel of power and control, think of it in terms of a bicycle tire. The very center of this is the hub, and that is power and control. But spokes are actually different choices of weapon. He may use intimidation. He may use isolation. He may say, you'll never see your kiddos again. And I got news. If I thought my abuser could take my children, I wouldn't tell anybody, and I would never leave. I would never leave them behind. And I know that for a fact. Maybe he minimizes and says, you know, you're so lucky. Look where you live. Look at the outfit you have on. You know, there are some women who just be so grateful to be in this relationship, or denying it altogether. You're crazy. I don't know why you're even saying it. You know what? You need to go see a doctor for sure. Using male privilege, whether that is, you know, it's I'm the boss and you're not, economic abuse, but all of these kinds of, as I say, choices of weapons are kept in a round circle, that bicycle tire, by physical and sexual and verbal abuse. Let's go to the next one, if you would. We also know that the abuser, there is a cycle to his behavior. It is not linear. This relationship is not linear with things that happen along the way. First he slapped me, then he kicked me, then he shoved me down the stairs, and that's when I was in the hospital, and that's when he broke my arm, on and on. But we know that the relationship is not linear. His behavior is actually cyclical, where there is a tension building phase, lots of fighting and arguing. And he's also at that time making a list of all your faults. He's saying, you know, she's a bad lover, she's a bad mother, she's a terrible cook. You know, she interrupts me, she doesn't show me respect, until this just builds up and bam, goes into the violent episodes, which can again be as different as every abuser. Whatever works, whatever gets the job done. And then it's often followed by what we call the honeymoon phase. He may apologize. He may say it never happened. I might get gifts. I might have a trip. And if it were linear and I thought that's where it could end, maybe there was hope for this relationship. But seriously, connect the two ends. And what happens is it goes back into the tension, into the abuse, into the honeymoon phase again and again and again. Let's do that next slide. And in the meantime, it not only increases in frequency, it increases in severity. So what I was saying, maybe it just starts with, he wants dinner on the table and all he has to do to get there is yell at me, right? But then he's yelling at me about anything. And then he just gets real sarcastic and he embarrasses me and puts me down out in public. Maybe he begins throwing things, throwing objects, punching a hole in the wall, moving into the physical of shoving and slapping and biting and punching, forcing sex, using a weapon. So there's this spectrum of violence that if we could have followed that woman who was in both Dallas and Fort Worth, maybe we could have come together and seen this escalation of the violence. The number one question, as I said earlier, should be, why does he do it? But the number one question I'm asked, either by juries or community folks, is why doesn't she just get out? Usually that's followed with a, boy, if that were me, I sure would. So I heard this thing, I just read this thing the other day. It's in a book by a guy named Evan Stark, and he wrote a book called Coercive Control. And in one of the paragraphs, it wasn't even the core of his book, and I thought it was just amazing. But in one of the paragraphs, he says there was a woman and she didn't change her clothes. She wore the same things every day. She didn't go out, and she just would pace back and forth in a very small space. Well, unless it's revealed to you, unless you know the whole story, that she's actually incarcerated and she's in a jail cell, you can't understand that behavior. Well, if you take that analogy and you look at domestic violence, the jail cell that she is in, the survivor is is invisible. These bars are invisible, but they are most definitely there. And it is these kinds of things like, you know, the verbal and the emotional abuse, and you're fat and you're stupid and you're ugly and you're a bad lover and you're a bad mother, and all the things that he slams me with, not to mention calling me the most horrific, dirty, disgusting names, and then punctuating that with a slap, a push, rape, sodomy, whatever. But those are her bars. And yet we judge her behavior not knowing that she is in a jail cell. You know, if we talk about, and if you want to put in the chat box why you think she would stay, why did your mother stay? Why were you in that relationship longer than you should have been? Why would a woman stay in a violent relationship? She stays because of the children. That's probably one of the things I hear the most. She stays thinking that's best for the kids, or kids should have a two-parent home. And what she doesn't realize is that for these kiddos, they are getting on-the-job training to be tomorrow's victims and be tomorrow's abusers. It is really, really sad. Maybe she goes to her pastor and he said, you know, you need to go home and pray about it. Jesus suffered, you should suffer. You need to be a godly wife, a Proverbs 31 wife. Or in Judaism, there's a phrase called shalom bayit, which means peace in the home. And she thinks, if he beats me and I tell, I will have broken shalom bayit. She stays because she loves him. She hopes for change. She might not speak the language. She doesn't know their resources because she firmly believes that it is her fault. If only she would get dinner on the time, quit crying, do what he says, then maybe it wouldn't happen again. But the number one reason why she doesn't leave, I can't remember if I said financial, more effective than a lock and a key. If everything is in his name, she's not allowed a credit card. Her paycheck goes straight into his bank account. And the money my mom sent me last Christmas that I hid in the bottom of a cereal box, now he found it and it's gone. Where do you think I'm going tonight? What does that mean? Just get out. But the number one reason is that leaving doesn't stop the violence. 75% of all women who are killed after or at the time that they are leaving. It's a very, very dangerous time for women. If you go to the next slide, I want to talk to you about a study done by a guy named Prochaska, the trans-theoretical model of change. He talks about if you want to change anything, there are 5 distinct stages of change: pre-contemplation, contemplation, preparation, action, and maintenance. Now, he was talking about the cessation of smoking. I've never been a smoker, and so I want to talk in terms of exercise. I've actually never been an exerciser, but at least I get that concept. I don't understand smoking. But where I am with exercise is I'm in pre-contemplation. I don't think about it. I don't do it. I go to work. I work all day. I come home. It doesn't cross my mind, to be real honest. Contemplation is, I jumped on that scale this morning and it went into another decade of poundage. And all of a sudden I'm thinking, what would it be like if I could order my clothes? I have a physical, guys, in like 3 weeks. And last time I thought she said lose 5 pounds, but maybe I mistook her and she gained 5 pounds. But anyway, I start thinking about it. And I haven't done exercise yet. Preparation is, I might call my friend Lori and get her trainer's name. I might go to Kohl's and buy a cute workout outfit on sale. Action is, I actually went to my friend Lori's trainer, but it made my knees hurt. So what did I do? I quit going. And then maintenance is like my husband. He's an exerciser for life. The point of this is, if you think in terms of domestic violence, pre-contemplation, your patient has never thought about even that's what it is. She's never thought about leaving for sure. Contemplation is, wouldn't it be nice if the kids didn't cry themselves to sleep at night? Wouldn't it be nice if I could give my opinion in my own house? Wouldn't it be nice if I wasn't afraid all the time? Preparation is, gosh, maybe she goes online and looks at Genesis Women's Shelter, or looks up domestic violence, or what are the resources, or what are the signs, or why does he do it, or whatever. Action, I still haven't done anything. Action is not just I got up and got out of bed and left. It is I can name it and claim it, that it is not my fault, that he is responsible for his behavior, and that there is help and hope. Maintenance, very hard for a survivor to get to because he won't let go. Now, in your practices, I want you to think in terms of what you can say, but you got to know where she is in these stages of change, right? If you tell me I'm in pre-contemplation, if you tell me, you know what, girl, and you're in action phase, because people like you and I are in action phase most often. If you tell this poor woman, girl, get up out, you got to go. Here's a go bag, here's a scrub suit, here's some toothbrushes, go tonight, go straight. I see your mouth moving, but I don't know what you're saying, right? So I want you to think in terms, what could you say to me to get me to contemplation? Have you ever thought about the impact on your kids? Have you ever realized this really is a crime and it's not going to get any better because it's all about, the cycle of violence and so on and so forth. And the other thing is, I don't have expectations that she is going to spill her guts, pack up her cares and woes, and get out. But if we can get her to that next phase, we've done a good day at the office. She may change. What is that? Oh, I thought somebody was telling me something. May go forward and, one step and then back 2. And that's okay because she does know that she can move forward. Real quickly, I want to show you a video. Genesis hosts the International Conference on Crimes Against Women. It is an amazing place where advocates and nurses and medical professionals come learning the best cutting edge investigative clinical techniques for all kinds of crimes. We actually developed a roll call training. I'm going to show you just the quick trailer on it, but it's, even though it's specific for law enforcement, I think you could take that out and say healthcare provider. So Marianne, could you show that?
Most people that have done any work in the area of domestic violence know it's all about control. What better control mechanism than strangulation?
What we know about abusers who use strangulation that makes them maybe a little different from other abusers who do not strangle is fear that they're trying to instill in their victim.
Most of the time, family violence escalates over time. So I know that when I'm responding to a call where there's been strangulation, that we're at the top.
I open the door, bright smile on my face, the fakest smile I've ever had on my face. And in my eyes, I'm saying, please save me.
Bruises that are deep within the tissue are less likely to be visible. And the darker a victim's skin tone, the harder it's going to be to see any bruising with the naked eye.
When he had a stitch on your throat during his assault, what was he saying to you?
By wrapping their hands around the neck of another person, they are telling us they're willing to kill. And this willingness to kill is not limited to their partner.
Once their ego is exposed, it doesn't matter anymore. So every officer is an enemy.
Behavioral changes are common. First responders can confuse this altered mental status as a credibility concern, often rating the victim's behavior as evidence of substance abuse, mental health issues, or attempts to manipulate the situation.
We need to make sure that we're building solid cases and we're getting the evidence that we need, but that we're also treating it as serious as it is.
Thoroughly investigating beyond whether or not someone could merely breathe to recognize that there's so much more that's going on below the surface.
When patrol officers arrive on scene where a strangulation has occurred, the golden hour of these investigations has begun.
So that is just the teaser, and there are, if you want to use this, you're welcome to it. Just get in touch with us, and there's no cost. We want everybody to see it, but there's some things in there that I thought might be really, really helpful. Somebody texted in about, just thinking about the skin tone differences and what bruises you can and cannot see. Another thing, and I hope you saw that it's a felony in the state of Texas, strangulation is, but the crime is impeding breath. So how do you ask somebody, hey, was your breath impeded? If she's talking about, that being strangled. I wouldn't know if my breath was impeded, but you can say, does she have headaches? Is there very rarely are there marks, but is she hoarse? Did she urinate on herself? Did she defecate on herself? Is there some time that seems fuzzy to her? But anyway, in addition to, that's one form of physical abuse. There are four main categories: sexual violence, marital rape is just about stranger on stranger. Only see, my rapist gets to jump out of the bushes anytime he wants. Women who are in domestic violence relationships, they say 70% of them will be raped or sodomized or both by their intimate partner. Stalking, absolutely. He doesn't want her, but he doesn't want anybody else to have her or want her to live without him. So stalking, the verbal and emotional abuse, as I mentioned earlier, can be just as deadly. It's a systematic effort to just diminish who that person is. I also want, and I'm going to turn this over to my amazing friend, Marianne Contreras with John Peter Smith Hospital. She is going to talk to you about the cost of domestic violence to you and your community. So.
Thanks, Jan. That was great. Every time I hear you talk, I learn something new, and I get another tool to put in my toolbox. So this is actually a calculator that was developed by Texas Health Resources. You can Google it online, and it gives you an idea of an organization, how much it costs to organizations if they have, say, 7,000 employees. I put in some numbers. We have about 7,000 employees at JPS. More than half are female, and I just put in a nice average hourly wage, actually, $40 an hour.
There we go. I wanted them to see it. We can advance that slide yet. Thank you.
Oh, okay. Did it not advance? Oh,
it is now. You're right where you should be.
Sorry, it must have been a little delay. Anyway, so this is just an average cost. If you look at the total annual cost that is not including any of the emotional or the psychological abuse that someone experiences, it's $2 million a year for domestic violence in a large company that is predominantly female. So that's a lot of money. So when people, when you're looking at your healthcare organization, this is a tool that you can use to work with some of your administrators in sharing the need to be screening. Did this one advance, Jan? No, it didn't. Okay, I don't know what the slowness is.
Calculator.
It's still, okay,
It worked for us.
okay. I'm sorry, you said it did or it didn't? Are we on Joint Commission?
I see it on the Joint
Okay,
Commission.
they are, I'm not, but okay, you must be moving
Okay.
with the
Okay,
audio.
I'm going to keep moving then. So we know as a healthcare organization, as all of us work in one, that it is a regulatory requirement set out by the Joint Commission. The Joint Commission does not tell us how to screen, what to document, how often should we screen, anything like that. It's pretty broad, and it leaves it up to us as healthcare providers, as nurses, as folks who work in hospitals and in clinics. It leaves it up to us to make those decisions, but it is a big decision to make. Oftentimes, as we are screening people, and I'm hoping the slides are advancing because they are on my end, if we have a tendency to look at our computer and we're not looking at our patients. And what's really important in building the trust with someone who has been physically, psychologically beat down is they're not going to be very trusting. And we want to be able to build the trust as we ask hard questions. And so while we're looking at our computer, getting everything documented, it's really more important to be sitting down and having a conversation in a safe space with all of our patients. So there's a lot of different health consequences that happen with intimate partner violence, and it's not necessarily the instant physical, like what we think of, a broken arm, a broken leg, what Jan was mentioning earlier. What we know is that when people are under a lot of psychological and physical stress, our bodies respond, and our bodies respond with an inflammatory response. It causes cascading of different hormones that actually impact all the health system, or all our systems in our body, our heart, our cardiovascular system, our digestive system, reproductive. Our nervous system, brains are actually impacted by all of the abuse. And this is similar to what we've learned about young children in the ACEs study, the Adverse Childhood Experience study. I mean, essentially, abuse could be called the adverse adult response system. So, you know, they not only are they hurting in that moment, but it impacts their health for the rest of their lives. During COVID, we all saw in the news all of the different uptake of different kinds of violence all across our communities. Victims were trapped in our homes. They couldn't get out because they couldn't work because the work had shut down. Then you all throw in there that you've got to educate your children. There's a loss of income. There is a lot of anxiety in the home. We saw an uptake in Tarrant County of intimate partner deaths for the year, almost threefold for the year 2020 of intimate partner deaths. And we're attributing a lot of it to the COVID and all the restrictions that occurred. People did not seek health care. They stayed away for a while from the hospitals. They were not able to access the resources in their communities as well. So here at JPS, we have over the last couple of years now really gone gung-ho in screening for intimate partner violence, especially at our entrance points to our health system. We've actually updated and revamped our screening policy that includes intimate partner violence and human trafficking. And when Jan was talking about strangulation, we've actually added a strangulation question into our screening as well, because we know through research that if someone has experienced non-fatal strangulation, what the research is telling us is that they are 800 times more likely to eventually become a victim of homicide. And so when Jan talked about testifying in court, and I do the same, I talk to people about how close those life enduring vessels are to the surface. You can see you have the carotid artery and the jugular vein super close to the surface of the neck, and they're not very well protected. And so someone that has actually been strangled can look like those two images that you're seeing there of the women, because often there are no marks. In fact, in about half of all strangulation cases, including fatal cases, there are no signs on the outside. Now, this young lady actually is a friend of one of my children, and she was strangled and beat to the point of unconsciousness. Now, you can see the petechiae, the bruising, the burst blood vessels caused from the occlusion of those vessels, from the occlusion of the carotid artery and the jugular vein, causes bursting, much like if you blow up a balloon too big and it bursts. She has that. She also, if you look at her neck, you can see that she also has some scratching, and that's where she was trying to pull the abuser's hands off of her neck. And the legal definition of strangulation is the external compression of a person's neck or upper torso in a manner that keeps that person from breathing. It inhibits the person's airway or the flow of blood into or out of the head. And Jan mentioned some of the physical symptoms that people have. Sore throat is the most common thing that people that have been strangled will, or choked out, as they say, will complain of. One thing that people don't realize during strangulation, as I showed you in the previous slide, this one, is that it doesn't take a lot of pressure to completely occlude those vessels. It takes about 4.5 pounds of pressure to occlude the jugular vein completely, and about 5 pounds per square inch of pressure to occlude the carotid artery. And so when I tell people that, they look at me like, okay, I don't know what that means. A trigger on a handgun is about 6 pounds per square inch to squeeze, and an average man's handshake is 120 pounds per square inch. So you see, it really, those hands can be quite lethal. What we're also learning as time goes on through research is that people that are in abusive relationships and that are strangled, they have chronic TBI, traumatic brain injuries. When you talk to folks, when we sit down and interview or are working with people who have had abuse, they're often very foggy, much like the video talked about how they don't remember as quickly. They don't remember sequential memories. When you have traumatic brain injury, you have a lack of oxygen that hits that hippocampus. And we know our hippocampus is part of the limbic system, and it's really important that it has oxygen to make a memory. If you don't have oxygen in your hippocampus, you can't really make very good and or sequential memory. It's kind of like a camera that has no film. And so a lot of times these women are, oh, well, she's just hysterical. She's not, she's making it up. She may remember something way down the line that she hadn't remembered right after the assault. And so we have to remember that women who have experienced physical abuse are often very much set up for traumatic brain injury. So why they stay? Jan's question, right? Why they stay? You know, when people first get together, they don't usually start in that abusive relationship. They're in that honeymoon phase that Jan talked about earlier. And that causes me to absolutely fall in love with you because you're treating me so well. I may not notice that those are a dozen red flags. I may be thinking those are a dozen roses. And while I'm thinking that, and while I'm falling in love, the neurochemistry in my brain, that a part of that limbic system, the part of our system that we have no control over, is oxytocin is being released. And, you know, when we think of oxytocin, a lot of times we think of birthing babies and things like that, and our bonding with our babies. Well, it causes bonding between adults as well. Also, it causes dopamine, which makes me really happy. It also makes me crave that person a lot. These are things that I have no physical or no will to control. So this is what's happening in people that when they first fall in love, and then when that cycle starts, you're already in love with that person. So here, what we really try to work on in our institution is creating an environment of care, a safe space to be able to talk to people about their experiences, what they're feeling, what they're experiencing. We want to make sure that we give them that space and we give them the idea that they can talk to us and we are going to be on their side. We are their healthcare givers, their providers, and we want to make sure that they understand that we're here for whatever they need. We want to make that person know that that it wasn't their fault, that things that caused them to be injured by their abuser. We want to make sure that we're not re-traumatizing them, saying, well, tell me again. Now, what happened after he hit you this time or after this happened? We want to make sure that when you interview or when you talk to someone that it's in that safe space. Also, what we're finding too is letting that person know what has happened in their brain with all the chemicals that have been released that causes these pathways, that causes them to behave in the way that they behave. Let them know that, because then they've been told at home all the time, you know, you're not worth it, you're unworthy, you're not smart, and so many different ways. If we let them know that this is a part of their brain that they have no control over, that also helps to build up their confidence and let them know that they can make different decisions as well. So what we're doing here is we're screening at major entrance points to our health system. As I mentioned, before we started screening, we really didn't even keep track of how many people that we had referred or if we even had referred anybody. Since we have started the screening in these different areas, we're finding that about almost half of our victims have experienced suicidal ideation, something in healthcare that we look at a lot. And in fact, about 40% of our victims are either admitted or put in observation when they are positive for intimate partner violence because of this suicidal ideation that they're experiencing. There's a lot of different tools that can be used to screen. We chose the HITS tool, which stands for hurt, insult, threatened, or screamed at, which spells HITS. We chose that because it's just a few questions. It's simple, and it's on a Likert scale of 1, where nothing ever happens, to 5, it happens all the time. And we piloted it, and we gave our nurses, our physicians some education. We talked about, Jan's talked about the power and control wheel, which is the Duluth model. We brought in our community resources, our local agencies like Jan in Dallas, that would be Genesis. Here it's One Safe Place and the Women's Center and Safe Haven. And we had them speak to our nursing staff because we wanted our nurses and our physicians to also trust outside folks. Just like we want to build that trust between the patient and ourselves, we also wanted our nurses to know that once they found somebody or the screener, once the screener finds someone that is positive, they can trust the community resources to continue to work with those victims and to hopefully help them make good decisions. We targeted very specific units. We did a pilot in a couple small clinics first, just to see how it would work, because what we found is that, you know, as in any nursing unit, we've got to fit their workflow. We want to know how it works. We don't want to just go in and say, one more thing for you to do. You need to screen, right? We wanted to see how the nurses reacted. One of our interesting findings, I told you that what HITS stood for is the first question on the HITS screening is, how often does your partner physically assault you or physically hurt you? And the nurses did not like asking that question first. They felt like that was just not the starter question. So we got permission from Dr. Sharon, who was the author of the HITS tool, to change the order of the questions. And we wanted to make sure that it would still be a validated tool. And he said yes. And so we listened to the staff. Anytime you're going to introduce some new screening, one more thing for that bedside nurse to do, we want to hear what their reaction is, because we really need to gain their buy-in and their trust. So we changed the order of our questions, actually. Some other things that we discovered as we began to roll out some of this education prior to the screening, we were starting just to roll out education on prevalence and how often abuse occurs and what the resources are, is we sat down with nurses and talked about their own particular biases regarding victims in general. That why doesn't she just leave? That's a big one, you know. I would leave. I know I wouldn't stay, like Jan said. So that is a big one. So we talked about what a victim is, and a victim is someone or something that's been hurt, damaged, killed, or suffered because of the actions of someone or something else, or because of illness or chance. But it's the actions of someone else. So we're trying to switch that blame, and why does he keep doing that? Not why doesn't she just leave? We discovered nurses had their very much personal opinions. In one of our screenings pilot areas, one of the staff that was there said, well, we don't need to screen that person. She uses crack all the time. And so the staff came back and said, well, wait a minute. Now, if she's using alternate substances, maybe she's self-medicating. And so, you know, some of it is just we've got to re-educate. We have to be able to identify our own biases and our own barriers and help each other to power through. This is what our screening looks like, and you can see we changed the order, and it's all very automated in our Epic, our electronic health record that we use. It even gives little prompts about, you know, how to say something in a trauma-informed way. And it gives the score at the end. We added the excuse the typo on the screenshot there. We added the strangulation question, and then our physicians had the buy-in. Because we did all of the education with them as well, and they now have some guidelines of what to do if someone has recently been had the experience of non-fatal strangulation. At the beginning, the nurses were nervous. The patients were refusing any type of referrals, but as the nurses became more confident and more aware and how easy the screening was, it takes about 1.5 minutes. It's not very long. Our referral rate, our acceptance actually climbed significantly. Our numbers have climbed in the total screening numbers that we're doing, and it's during, I will say now, it has been a little bit harder because we have a decrease in nursing staff, as I'm sure a lot of you all do, and we have a lot of travel nurses that now we're going back and educating. If you remember the slide that I had on with the healthcare worker looking at the computer while the patients were bleeding to death behind the healthcare worker, this is something as our badge backer. And when we use our badge backer, it's actually on all of our different backings, and it causes us to show the patient this particular badge backer, but it has the very intentional colors. Blue is happy, red is angry. You know, so a little bit more of health literacy. And we lean toward them with our badge and we say, well, so how often does your partner scream or threaten you on a scale of 1 to 5? And that question, again, from Dr. Sharon, normalizes violence. I would be much more inclined to answer that question versus if somebody said, well, does he hurt you? You know, that makes it abnormal. But when you say, how often does your partner? And on the back of our badge backers, we have our different resources out in the community that our staff is very, very familiar with, have relationships with. And now it's become very much a two-way street. Our resources will call us now. We've got a person coming to your ER that just recently got strangled. And we have really developed this safety net and a village, essentially, of people that are trying to help and get the word out that this is not a normal behavior and that there are opportunities to make different choices and, you know, develop safety plans. We are even now piloting some forensic nurses that mainly focus on intimate partner violence. And we're just looking to see how we can continue to expand this program in identifying, recognizing, providing not only physical and emotional support, but the resources that they need to obtain some help. One of the hardest things is that whole rescue piece. The nurses want to make sure everybody goes home and they've had their penicillin shot for their strep throat, things like that. We like to fix things. But what we really had to focus a lot on is telling our staff that the most important thing is that they're planting that seed of into the victim or to your patient's brain. You're implanting a seed that says, you know, we're here. Every time you come, we're going to ask you these questions. And we've seen that patients have come in and had negative screen, and the third or the fourth time, they have a very positive screen. So we're developing that trust. And in conclusion, we want to do the best that we can until we know better. And then obviously when we know better, we want to do better. So a little bit of summary, and then I'm going to stop sharing. And if you all have questions, there's mine and Jan's and my reminders, all the different things, right? Questions, there's our email. We are more than happy to answer anything, to share any tool that you possibly could want to take this back to your organization and look and see what's a good fit for you. So there we go. I've stopped presenting and I'm going to make it big. So questions or comments?
I see one in the box that said, could you show that resource slide again?
Yeah, I sure can. Oh, well, I guess I got to share my screen first. Hang on.
I guess that was what was on the back of the badge backer. Is that?
Yep, I'm getting there. Let me tell you, it's
okay.
Yeah. Okay, are you seeing my screen?
Not yet.
Not yet. Okay, hang on. I apologize. Okay, let's see. Share content. Screen. Now can you?
Yes.
Okay, hang on. Let me scroll it back. Okay, now it should be popping up. Is it there?
Yep.
Perfect. Jan, I can't see the questions when that's up, so
oh, okay.
you've got that.
Thank you. Thank you for doing that.
All right, I'm going to take it back down again. Snap a pic. There we go. Okay.
Marianne, there were some things on here. Nurse residence equals new grads, question mark. Yes, nurse residents are new grads.
They are new grads, yes. And anytime you have a nurse residency program, they always need a project. And that's what we tag them with. Yes, they are all new grads. Super eager to change the world, right? You remember back when you were a brand new nurse.
And John Patton just raised his hand.
Jonna, you can unmute yourself and ask your question or type it in the chat.
All right, let's try unmuting. Can y'all hear me okay?
Yes.
Yeah.
Just because it's kind of a long question, I thought that I had heard a couple of legislative sessions ago, somebody was trying to introduce a bill which would make Texas a mandatory reporting state for adult on adult intimate partner violence. I hadn't heard about it since, so I assume that that was either not something that I was hearing correctly or that died. Is that still the case?
John, I'm on the Texas Council on Family Violence Public Policy Committee. And I got to tell you, there's goofy crap that comes up every legislative session. That has not passed. You're exactly right. It did happen way back in California. When I first came to Genesis, they passed it to where it was mandatory reporting for domestic violence. And what they saw pretty quickly was that survivors were not reporting. And if they did come in, they wouldn't say it was domestic violence because the insurance companies were considering it a pre-existing condition, whatever. And so that is, I don't believe it's even any longer an issue in California.
It is a felony. The strangulation is a felony, so people can be put away for a much longer period of time now. And what's interesting here in Tarrant, and I'm assuming, I don't know, Jan, in Dallas, in Tarrant, we actually have an IPV prosecuting team, and they study all of this. They go after, and they make sure that she's protected.
In the misdemeanor unit there in Tarrant County, as we do here, there is a specialized prosecutorial unit. The felony cases, however, are in both counties are dealt out almost like a hand of cards, which is unfortunate because it's kind of a game of whack-a-mole for the victim. It depends on what judge you get. Courts have been dark. That's been a problem. The whole, where my head is spinning around. I may set it on fire by Friday over the Senate Bill 8, which is very, very unfortunate with regards to victims of domestic, women all over the place, but victims of domestic violence who come to Genesis not knowing they're pregnant. One more rape baby, to be real honest. It's really sad. We need to let our voices and our votes be heard. So, John, thank you for paying attention to that legislative session, because when we don't, oh my gosh, but they slip by us.
Yep. So, show of hands, how many people are actively screening in your institution? Either hands or in the chat box that you know of. I'm awesome. There's some hands there. That's fantastic. We did not know that we were not doing a good job for a very long time. And now every month we monitor it. And because of, I mentioned earlier, our screening numbers are down a bit, as well as our referral numbers compared to what they had been. So now we're bumping it back up, and we're going back in and educating. It's very labor intensive to do that, but it's so important.
Someone was saying in the chat box, I think a lot of nurses don't know it's a statutory requirement. Now, are you talking about mandatory reporting, which it's not?
No, that's me again.
Oh, okay. Okay.
So my understanding is that Texas requires nurses who identify potential victims of domestic violence to document that they suspect family violence, document the reasons why they suspect that, and then provide the victims with the notice to victims of intimate partner violence handouts. It's touched on in some of our training in several places, but I have not seen a good, solid, really focused education about that. It's just kind of slipped in as an also point on a lot of stuff. So I think, our assessment questions have that, do you feel safe at home question, but the really like the HITS assessment tool and the really deep dives that enable folks to get potential victims to be willing to open up and talk about it. I still think there's a lot of uncertainty and a lot of folks are not really aware of it.
Yeah, it's not, I think it's a JCO thing. It's not a statutory thing that you have to ask those questions in order for you all to receive certification. But let me tell you this, I am probably healthcare person's worst nightmare, because if they do touch on it, like I thought I'd broken a rib the other day, and I was going down here to one of these emergency things in the night, and the guy is going down, do you smoke, do you this, do that, do this, do that, and then he said, are you safe at home? And I was just like, thank you so much for asking that. Okay, so do you know that 1 out of every 3, I mean, this guy was 2 in the morning, he's like, what the hell? But understand the way you asked me and what you asked me. So I went to this new OBGYN, and out in the lobby, they were like, hey, fill this out, and so I'm sitting out there with a clipboard, and it was, are you at my age? Okay. Again, I don't know if it was just for me or it's for everybody. Are you sexually active? Well, I'm looking around at 100 people in the waiting room, and I'm thinking, I'm not telling you the truth on this. I mean, whatever it is, I'm like, oh, hell's yes. At my age, you can't get it enough. I mean, I just went on and on this story, which I'm sure the nurse was like, is this too much information, Marianne? Are you fixing
No,
to?
this is great.
Okay.
This is great.
But I mean, like, you understand, I don't know you. I'm not going to talk about my sex life, and I'm damn sure not going to talk to you about my abusive husband, because either he's right there, or how do I know you're not going to say something? I don't know you. I don't trust you with my biggest secret that he hurts me in my own home. So I love the badge saying, 1 to 5, because I would have answered that 4 or whatever. Not on the sex life thing, but definitely on the abuse thing. And I just think that's it. I think we have to keep asking, guys. We just have to keep asking. I love what you said, Marianne, about, and the next time you come, we're going to screen that again, and we're going to ask you again. And please know we're here to help every single time. Maybe it does take 3 or 4 times. And if in fact, John, what do you do? Where are you?
So I am a nurse, nurse educator with Baylor Scott and White in Temple, but I began my career working with NOAA Project in Abilene.
Oh, well, that's why you know the deal. NOAA Project is awesome in Abilene. But, sometimes if I went to JPS, I might ask particularly for Marianne, because she had been so kind and asked me a real hard question one time. Or if I go to Baylor Scott and White in, what'd you say, Temple? Temple? What'd you say, John?
Yes, ma'am. I'm located in Temple, but we're all over now.
Oh, I know. Oh, I know. You guys are amazing. But maybe it's that personal connection, and I don't know how you would be able to see the same patients, but man, that would make a difference. Oh, and by the way, if you want us to come down, I'm speaking for Marianne, we'll take the show on the road. I'll come down to Temple, and I'll do, grand rounds or all shifts or whatever. Also, I want to mention again the Conference on Crimes Against Women in Dallas. We will be in May in person, 3.5 days of all kinds of how to treat it, how to talk about it, how to understand it. A big pre-conference is on strangulation. 2 whole days before our conference starts, it's 100% strangulation. Very, very interesting. Anyway, best speakers anywhere. We'd love to have you come. Anything else?
We have time for one more in the chat. Somebody was asking if you know anything about HAVI, the Health Alliance for Violence Intervention.
HAVI, they're an awesome organization. I am more familiar with their interventions and their programmatic structure surrounding firearm violence than I am with Intimate Partner. I haven't delved too deep on the Intimate Partner with them. And if you want the video, somebody asked about the video clip as well. If you will send Jan your email, she will be happy to send it to you, or me, I think. So yeah, we would love to take the show on the road, as Jan said. This is really, it's very important. It's often overlooked, and I think a lot of the overlooking of screening has to do with old sets of values. Why doesn't she just leave? There's so much new research into the damage from both psychological and physical abuse that we all need to be on the same bandwagon, and we certainly as a village could do a lot of good work together.
Well, I can't thank you guys enough. All the positive comments that's in the chat. This was an eye-opener. The statistics. I hope you get requests to take the road, show on the road, because the more people we can educate, the better. I did put in the chat that I am going to put the recording on our website because these lovely ladies gave us permission. Everybody who attended today will receive an email with the link. Give me a day or 2 to get it posted, but I will give you the link so you can share this with your coworkers, and please reach out to any of us if we can ever do anything for you. Thank you so much for your time today. Thank you, Marianne. Thank you, Jan. Really appreciate you sharing with everybody.
Thank you, Patty.
Thanks.
Appreciate you all coming.
Thank you so much. Y'all take care.
Take care, everybody.
All right. I think I can hop off.